Perfect. Thank you so much to both of you for those wonderful presentations. I'd like to go ahead and start off with what I think the million or $100 million question is here, and that's are rapid antibiotics and antimicrobial stewardship at odds with each other?
I say no. I say they're dependent on one another.
Yeah, I mean, I think the one makes the other necessary, right?
Mm-hmm.
And even though we are, kind of informally on opposite sides of this debate, just like Dr. Simpson said, I don't think there's any actual, if you followed us around at the bedside, you would not see a dramatic difference in our practices, other than me watching Steve and trying to imitate him to the greatest extent possible.
I was going to say, other than you being smarter at which antibiotic to actually choose.
But I think that actually does pivot into an interesting question. What's a broad spectrum antibiotic? And that definition, I think, was one of the points of contention between IDSA, SECM, ESICM, and in earlier iterations of the surviving sepsis guidelines. What is a broad spectrum antibiotic? Technically, ceftriaxone is a broad spectrum antibiotic. Mm-hmm. And if you are a 25-year-old community dwelling, basically immunocompetent adult coming in sepsis or septic shock, I would posit to you that there is an overwhelming likelihood that what you have is fundamentally a ceftriaxone deficiency disease. You have pneumococcus, meningococcal infection, some bowel catastrophe, group A strep, group B strep. Right, and then MRSA is the outlier, so we'll give vanc if the patient is in shock. Right, that is probably what you have. Now the question then becomes, well, how lucky do you feel? Right, there is a certain emergence of community-acquired ESBL infections, for example, for gram negatives. Is it common in young immunocompetent community-dwelling adults? No. Does it happen? Yeah. So should we give cefepime instead? Should we give piptazo instead? Should we give a carbapenem instead? Or if we say we should use the broadest available drug, well, then everyone should be getting probably ceftazidime avibactam, right? Yeah. Well, we all kind of agree that that's too far. Like we're not going to be giving ceftaz avibactam empirically. But then why not? Why a carbapenem in that setting? And I think that is where a lot of the heat comes. Is no one, and I'm a critical care physician, but I am still practicing consultative ID when I'm not in the unit. And I think that source of tension is hard, and that has to be really driven by local antibiograms. Around here, your odds are better with cefepime for anti-pseudomonal coverage here in North Carolina than they are with the carbapenem up front.
Wow.
Right? But that may not be true everywhere. In fact, I posit that it is not true everywhere.
Right.
And figuring out, so I think it goes back to just like with Dr. Simpson's first slide about the road rash, is how lucky do you feel? Or rather, what's your risk tolerance? Mm-hmm. And if you have someone who is eyes are open, talking to you, has a non-embarrassing blood pressure, maybe you can afford to make your broad spectrum therapy a little bit narrower, depending on their epidemiological risks. Mm-hmm. And someone who's coming from a nursing home with a blood pressure of, 70 over nothing, you have no such leeway, and you have to drop the bomb on it. In that setting, I posit that the role of stewardship is not what you do in the first 48 hours, it's what you do after that.
I don't disagree with a word of that.
I think those are great points, and I'd like to use that to springboard into sort of an adjacent space, right? So one of the limitations, if you will, of a lot of the sepsis literature is that it focuses on community-acquired sepsis and patients coming into the emergency department. But I wonder if you both might walk us through your approach to antibiotics in a patient who's been in the hospital for 5 days and is deteriorating, and you don't know, is this due to sepsis? Is this clinical deterioration due to other causes? And they're certainly at risk for more of those resistant organisms and other healthcare acquired pathogens.
Should the amateur go first? I'll go first so Dr. Maves can tell me where I'm wrong. But no, after, as you well know, after someone's been in the hospital for 48 hours or thereabouts, we tend to believe that new infections, if we believe it's a new infection, are hospital acquired, and you are bound to have to cover most of them with coverage for MRSA and for Pseudomonas. So you've got to be got to be more careful. So even the 20-something-year-old who came in with a motorbike accident, who suddenly has fevers and mental status change 72 hours into the course, you've got to still cover that person because we have such nasty stuff outside. As far as diagnosing those people, that is very difficult. I think, Dr. Pendleton, you well know, and you have published in this area, that people tend to forget that this could be a new infection. And I think that's one of the places where we have room for improvement in the hospital, because, yes, you cannot treat every patient that develops a fever in the hospital. But I would posit that you do need to evaluate them a little more carefully, because we clearly miss those cases a lot of the time, and we delay the antibiotics in those people much more than we do in people who come into the emergency room.
Yeah.
Right?
Yeah, I mean, absolutely. It's for me, I would say one of the first thing I'm looking at is physiologic parameters in addition to the new fever, right? But obviously the microbiology is radically different, and that will depend very much on where you're coming from. Once you've been in the hospital for 72 hours, we've inoculated your bowel with enough Pseudomonas that narrower spectrum coverage is clearly no longer appropriate. Although still a lot of those do turn out in the future to be, susceptible, gram negatives or staph or things of that sort. But,
yeah, they
but
do.
up front, that's not a bet you can take. I do like to remind people, especially in the reasonably stable patient, to look for other things. Look for DVT. In the intubated patient who can't talk to you, look for things like gout, other things that can sneak up on you, and you're really only going to identify by a good physical exam. That's just a kind of a standard observation. But yeah, otherwise, I couldn't agree with Dr. Simpson more that the story completely changes after the first few days, and a particularly dramatic example of that are patients who develop sepsis after a major burn. And
Right.
the microbiology of burn units, that gets even more challenging because the physiology of a severe burn looks so much like the physiology of sepsis that teasing that out is an entirely separate and especially challenging puzzle.
Sure. And then to move on to one thing that I think I heard both of you agree on, right, which is major opportunity for compromises in terms of when we can stop or narrow antibiotics. Bearing in mind that, it's like 50% or less cases of sepsis actually have positive cultures to help guide you. How do you both approach stopping or narrowing antibiotics in these patients?
Mm-hmm. Yeah, Ryan, why don't you go first last time?
I mean, I started a couple of kind of core things I think of. That there are two things I do believe in microbiology: that if Staph aureus is present, Staph aureus will grow. And if Staph aureus doesn't grow, Staph aureus probably isn't there. And so vancomycin de-escalation after 48 hours of negative cultures is one of the first places I start. I mean, you have to kind of define your syndrome, first of all, right? That even if we don't have a positive culture, we usually have some idea of where in the body it is coming from. And so my duration of therapy in a patient who is hopefully improving on therapy is going to be based on whatever I think their syndrome is, be it urinary, be it abdominal, be it pneumonia, or what have you. Early vancomycin de-escalation. I think with the advent of MRSA PCRs, we've done a good job of rapidly de-escalating people off of vancomycin based on MRSA PCRs, and some of the multiplex respiratory panels have also been helpful in that regard, getting us quick identification of causes of pneumonia. But yeah, 48 hours of negative cultures or a negative compatible molecular test getting vanc off. The other thing I believe is Pseudomonas. Generally, if Pseudomonas is present, Pseudomonas will grow, and if it doesn't grow, it's probably not there. Now that gets a little trickier because with Pseudomonas, we have so many other resistant gram negatives, and I think when a lot of us, like when the three of us say Pseudomonas, we're kind of shorthanding it for drug-resistant nosocomial gram negative rods. Right. So the absence of Pseudomonas doesn't help me de-escalate to quite the same extent. But getting vanc off is a big step. The other things that I think about in the truly culture negative one is having some idea of the microbiology of my unit, just knowing what are the odds. If I don't know what it is, it will probably be something that fits into this box. Biomarkers are the thing that we're all kind of hoping for to see if we can find that there is good data to support procalcitonin-guided discontinuation of antibiotics, not initiation, but discontinuation in a protocolized manner. I will occasionally use that to satisfy myself after a reasonable duration of 5 to 7 days of therapy in a patient who's getting better. I might grab a pre and post procal to satisfy myself that, okay, I think I can emotionally stop this. And that's based, I think, on some reasonably good RCT data. The problem is that there are too many confounders to procal to really let us breathe completely easily based on that. AKI, CKD, and ESRD, candidemia gives you a procal, all of those things. So if we take those into account, that's a general approach. That's a very broad one. But all of this is in the context of clinical improvement and the patient who's not improving. I'm reluctant to take that approach. And the only, again, kind of hard rule I have is, well, if nothing grew, I could at least stop the vanc.
Right.
And Dr. Simpson, I'm just curious what you think.
Yeah, that's about the same approach I take. I would like to know, I feel very comfortable at 72 hours on stopping the vanc. If you got data about 48, I'd love to know about it, because I would really rather stop at 48 if I can.
That's a rule of thumb. That's not a law of physics.
Yeah. It's but my lie is if I don't see it by 72 hours, the vanc is gone without.
Very sensible.
With pneumonias, we are paying attention to our nasal swabs and our MRSA screens, and if that comes back negative, then we often get them back in an hour or two. Then I'm off the vanc immediately for sure.
There's a couple small interesting observational studies looking at the predictive power of nasal PCR screening for intra-abdominal sepsis. Actually, that it may have some correlation. I don't think the data is quite as strong, but I have to admit that I've used it as an excuse to stop vanc.
I'll buy it. The MRSA has to come, or the Staph aureus has to come from somewhere. And it probably originated up here.
Great. I think it seems like we're coming up on time here. So I was wondering if either of you had any parting remarks that you wanted to make before we sign off.
I do have something that's real important. I think we need to dwell on, and that is because I emphasized in the talk, and we haven't gotten to it yet. And that is that one of the tough things to do is to decide whether infection is present or not. The Surviving Sepsis campaign, and literally I was responsible for one of the responsible parties for the section on that graph that Ryan showed is okay, if there's shock and infection is anywhere in the differential, great. If there's not shock, but you have clear evidence of infection, antibiotics. It's when you're not clear on antibiotic or on infection that antibiotics, where we said, okay, maybe you can put the brakes on this. So just to remind people that the original sepsis definition promoted by Roger Bone actually didn't say what it came to be over time, which was suspected infection. That's what we said. What they said was evidence of an infected organ, but you don't have to have microbiological proof to start, right? So the first thing I want people to remember is go back to your first principles that you learned in physical diagnosis and ask yourself, what are the signs and symptoms of pneumonia, pyelonephritis, cellulitis, meningitis, and go through it systematically that way. Then the second thing that I want to say is we actually have diagnostic aids now that are available on the market and FDA approved for helping us to discern in those difficult to discern cases. One is the monocyte distribution width, which comes on CBCs. One is the IntelliCept by Cytovale, which looks at distensibility or squishability of neutrophils, and one is called the Septicite Rapid, which actually looks at gene expression for host response genes to bacterial infection. All of those are on the market. They are purchasable. They can help you in those hard to discern cases, and they all come back. And well, the Intellecept comes back in 10 minutes, the Septicide in an hour, and the MDW comes on the CBC you sent. So however long that took. So they all are rapid and can help you come down for the high probability infection side and know to give your antibiotics rapidly sooner, and vice versa. They will. There is a low risk of infection group on all of those tests.
Yeah, absolutely. I think the talk about biomarkers is interesting. You know, I've become a little bit of a biomarker nihilist in the last few years, but actually I am very, very excited about the possibilities of monocyte distribution, particularly because that is, you know, it's on that differential. That is a thing that could become available in especially low resource settings, where getting another machine for another assay would be challenging. And we're actually going to be looking at MDWs and discriminative power and cardiogenic shock versus bacteremic septic shock here, hopefully soon, as just an observational study.
Yep.
So, yeah, and concurrently with that is going to be improved rapid pathogen microbiologic diagnostics, pathogen directed.
Yes,
so, you know, the multiplex PCRs from whole blood have not perhaps panned out as well as we might have hoped, but there's some very exciting work looking at things like next generation sequencing of cell-free DNA, for example, which potentially could be. There's a very cool observational series from Germany that looked at the impact of that on therapy in patients with abdominal sepsis, and that could be the thing, the holy grail, or at least some variant of the holy grail to help rapidly identify pathogens and then narrow our therapy more quickly than we're able to do now. So, yeah.
Thanks both. I think those are great points, right? Going back to something that I think was in both of your presentations that we all agree on, right, is the delay to shock recognition is critical, and anything that we can do to help move the needle forward on that is going to get people earlier antibiotics and also help improve their outcomes. So it sounds like we have a lot of exciting stuff to look forward to in the future. All right. Anything else that we should talk about?
I'm sure there's plenty, but they're going to give us the hook pretty soon.
Yeah, I figured as much. Okay. Well, all right. Well, thank you, Dr. Simpson and Maves, very much for your time. This was a great discussion, and thanks everybody for sharing part of your day with us.
Well, thank you all so much. Take care.
Thanks a bunch.
All right, that's a wrap.
They can wrap it there, and
There you go.
cut that however you think, John. And possibly, since we went over a little bit, I suppose you can give little snippets here and there. And
I was actually thinking halfway through, there's a nice, the presentation and then the debate is a very kind of distinct two sections. We might be able to break that up and kind of be able to bounce between those.
Yeah.
And so I'm gonna ask our editing team what they think, but some thoughts.
That'd be an interesting way to do it. Set them side by side and say, okay, here's the presentations, here's what was said afterwards. Yeah, that'd be cool. Katie, nice job.
Thank you. Okay, first one done.
Thank you so much.
Yeah, exactly. Well, thank you all for staying on and give us and. Apologies.
This interfered with my lunchtime that I was promised. No, I'm just kidding.
12:07. It's still lunchtime.
True.
Yeah, that's a fact.
Yeah. Well, it was a ton of fun. Thanks, guys. That was great.
That was a ton of fun. I enjoyed the heck out of that.
Absolutely.
Thanks.
Well, everyone have a lovely weekend.
Thanks.
Thank you also.
All right. Talk to y'all soon.
We'll see you soon.
Take care. Bye.
Yeah.